today what we're going to talk about is Parkinson's disease, because I want to and I'm in charge. Parkinson's disease is the second most common neurodegenerative disease following Alzheimer's, so it is worth knowing like a little something about it. So what is it? Parkinson's disease is a condition where there is a progressive reduction of dopamine in the basal ganglia, which leads to disorders in movement. And the symptoms are characteristically asymmetrical, with one side affected more than the other. And there is like a classic triad of features that are present in Parkinson's disease. So let's start by breaking down what that actually means. First things first, the basal ganglia is a portion of your brain, and it's basically a collection of nuclei that just sit below the cortex. And I don't know how to include pictures in these videos, so if that means nothing to you, just Google it. But if we're just gonna be super reductive, super simple, the basal ganglia is very, very much like the innermost portion of your brain, and it resides in the midbrain, which is convenient. It is made up of a couple of different parts, all of which contribute like slightly different functions and are implicated in different diseases. But for Parkinson's, we care specifically about the substantia nigra. The substantia nigra is part of the corticobasal ganglia thalamocortical loop. Yes, cortico is in there twice. No, I do not name these things. We're just going to call it the CBGTC so that I can continue to pretend that there is any kind of intelligence in medicine. Basically, the CBGTC is used to initiate movement, control skeletal muscle, and to adjust posture. And it's made up of two main pathways, the indirect and the direct. Both pathways are dopaminergic, which means that they rely on dopamine as their neurotransmitter. And so the balance of their activity is kind of dependent on the amount of dopamine that is around. Dopamine excites the direct pathway and inhibits the indirect pathway. And the indirect pathway is inhibitory to movement because the inhibitory pathway or the indirect pathway is characterized by D2 receptors, which are inhibitory. So dopamine inhibits the inhibition of movement by the indirect pathway. I wish there was a less complicated way to explain that. I'm sorry. Basically, dopamine stops the indirect pathway from stopping movement. Look, I could talk about this for hours and neither you nor I would understand it better, so we're just gonna move on. In Parkinson's, what you get is this thing called Lewy bodies. And Lewy bodies are aggregates of misfolded alpha-synuclein and other proteins within neural cells, which causes damage to them. And you can see Lewy bodies in other diseases, but in Parkinson's particularly, it's a neurodegenerative disease of the fun dopamine nerves in the substantia nigra of the basal ganglia, and it's the loss of those nerves that lead to the characteristic triad of Parkinsonism. And the classic triad is resting tremor, rigidity, and bradykinesia. And bradykinesia is the medical term for like slowness of movement. Patients with Parkinsonisms often have difficulty initiating movement and difficulties with swift movement, which now that you understand that what's happening in the substantia nigra, you can maybe kind of get why these symptoms are related to that. Awesome, so now we understand the basics of what's going on and the classic symptoms. We're good to move on, we're killing it. Of course not, because it's illegal for things to be simple in medicine. So, while you may be expecting that all of your patients with Parkinson's will present with that classic triad, there's actually a myriad of patient presentations that you have to be mindful of. Signs of Parkinson's disease are progressive, so the earlier they're caught, the better. And that's why you have to pay attention and be mindful of the fact that no matter how well you know a disease from a textbook, you're going to be talking to a whole-ass person who has a whole-ass life. Usually, Parkinson's disease are motor signs, and they're going to be asymmetrical and unilateral at onset, and then they might progress to being contralateral over time, which is to say you should see signs on one side of the body and they should be worse there, and usually only on one side first. But what's important to remember about Parkinson's is while Parkinson's has its clinical stage with its characteristic, motor defects, patients can actually experience a prodromal or preclinical stage. So what is in that preclinical stage? So what you're going to see are things like constipation and anosmia, which is loss of the ability to smell. You're going to also see sleep and mood disturbances. Your sleep disturbances are usually REM sleep behavior disorder, restless leg syndrome, or excessive daytime sleepiness. And your mood disorders are usually or most commonly depression, apathy, and or anxiety. And if you picked up on the pattern there, you get a gold star because you are right. All of these disorders have also been linked to a dysfunction or dysregulation of dopamine in some way. So it makes sense. The other two, constipation and anosmia, are not as linked. But although constipation is actually a really interesting and important part of the prodromal syndrome because it's one of the earliest signs of Parkinson's disease. And ultimately it turned out to be really, really useful for how we began to understand the mechanisms behind Parkinson's. For my medical students in the audience, please do not jump from I have constipation to I have Parkinson's. We're going to talk about etiology and risk factors later. Just hold on. It's going to be okay. So that was the prodromal or preclinical stage. And let's talk about the actual clinical stage. So these patients will display something called Parkinsonism, which fucking makes sense because they have Parkinson's disease. And Parkinsonism is this classic triad of symptoms of resting tremor, rigidity, and bradykinesia. And it's important to note that's not actually exclusive to Parkinson's disease. Other diseases can present with Parkinsonism, like Lewy body dementia. So having Parkinsonism doesn't mean that you have Parkinson's disease. And I'll talk a little bit more about that later, but let's kind of focus in now on that triad of symptoms and what that means. I already talked about bradykinesia a little bit, so I'm going to just break down the other two symptoms right now. So resting tremor, by definition, means a tremor at rest. I'm very helpful. But actually, the resting tremor of Parkinson's is characteristically in the hands, although it can involve the legs, the jaws, the lips, or the tongue. And since it is a resting tremor, it should subside with voluntary movement in the area, which means moving that part of the body with intention should diminish the tremor. And the things that will make the tremor worse are often things like emotional stress or being sick. Tremor in Parkinson's is usually called a pill rolling tremor because apparently it looks like someone rolling a pill, which I personally don't agree with. But again, I'm really not in charge of naming here. I think the hot takeaway from this is people used to roll pills in their hands, I guess. The rigidity is an increased and persistent resistance, say that 3 times fast, to passive joint movement regardless of speed, right? The rigidity can also be exacerbated by certain maneuvers, so you can actually tease it out when you're trying to test someone to see if they're demonstrating signs of Parkinsonism, with certain maneuvers, which we're not going to talk about because, I don't even know how I would demonstrate that to you. In Parkinson's disease, you're going to see often what is called cogwheel rigidity, which actually kind of does sound like what it is, unlike pill rolling tremor. So with these patients, what you'll see is it's kind of unlike seeing a smooth movement. They just move their arm from one spot to another. You'll get this kind of like ratcheting or these small jerky movements. And that will happen even if someone else is moving the limb for them. Other aspects of the clinical stage of Parkinson's disease are things like postural instability and gait abnormalities. And now these tend to come a little bit later in the progression of the disease, so that's why they're not really considered part of the 3 hallmarks of Parkinsonism. But they are still important, right? Patients with Parkinson's disease are a fall risk because of this instability and this gait abnormality, and also because they have these slowed movements. So it's hard for them to quickly adjust if they, start to slip. So it's very important that you set them up in a way that they are safe and able to maneuver their lives comfortably. And then there are some other findings like signs of dystonia or stooped posture or other weird neurological reflex things like hypomimia, which is just they don't make as many facial expressions, and unhabituated glabellar reflex, which it's just not worth worrying about. Also fucking micrographia, which is when the size of a person's handwriting reduces. But if you're relying on a patient's handwriting size to tell you if something is Parkinsonism, these videos aren't going to help you. Nothing will. Other important things are there are also non-motor signs. I know we talk about Parkinson's disease as predominantly a motor disorder, but there are going to be things like autonomic symptoms. And those are things like orthostatic hypotension, urinary urgency, impaired sexual function, and oily skin. And then there's also a collection of neuropsychiatric syndromes like depression, cognitive impairment, behavioral changes, disordered sleep, fatigue, and then also, changes to your ability to smell. Since it's come up twice now, no, I don't know why Parkinson's disease affects smell. No one does. We have a couple of theories because, we like to do that in medicine, but we don't know. As a small pro tip, anosmia or hyposmia, right, diminishment or loss of your ability to smell, will often present as changes in appetite because your smell and your sense of taste are so closely linked. Yeah, it's buck wild. Okay, so now we know the basics of what this is and we kind of know what it looks like. So who does it affect? We are pretty sure at this stage that it affects men and women the same. Now, This was confusing for a period of time, and there's been some research in both directions, but we're pretty sure that it affects men and women equally. The age of onset does tend to be around the age of 60 for, idiopathic or sporadic cases, but genetic causes can actually present earlier, and about 10 to 15% of all cases of Parkinson's disease are familial. In terms of our other risk factors, environmental factors like exposure to manganese and carbon monoxide might play a role. Some elements of diet and metabolism have been kind of linked in. So low levels of vitamin D, very high iron intake, obesity, those have all been linked with Parkinson's disease. Final big thing is a history of traumatic brain injury. It turns out damaging your brain can damage your brain. Most cases of Parkinson's disease are considered to be idiopathic. We commonly say Parkinson's disease is idiopathic, and that's just a fancy medical way of saying we have no idea what causes it. We have identified a couple of contributing genetic factors. So we have our alpha-synuclein, or our SNCA, which, impairment in that is kind of implicated in the formation of Lewy bodies. So that makes sense. We have our glucocerebrosidase, or our GBA, and a mutation in the GBA gene is a common genetic risk factor for Parkinson's disease. And they're associated with altered autophagy and lysosomal function and that could potentially result in an impairment of alpha-synuclein clearance. So, maybe that's how it kind of comes in and creates Lewy bodies, et cetera, et cetera. We have dardarin, or LRRK2, and a mutation in LRRK2 gene is the most common dominant inheritance Parkinson's disease, whereas Parkin, or PARK2 gene mutation, is the most commonly caused recessive inheritance of Parkinson's disease. And if that wasn't already fucking insane enough, we also have this insane thing called secondary Parkinsonism, which is basically induced Parkinsonism, and most common causes of that are medications, and we call it drug-induced Parkinsonism, or pseudo-Parkinsonism. And this is often associated with a frequent use of anti-dopaminergic drugs. So, some drugs that you want to be mindful of, potentially inducing Parkinsonism in are your typical antipsychotics like haloperidol, some of your antiemetics like metoclopramide, some calcium channel blockers like amiodarone, because that thing will fuck you up, and then valproate and lithium. It can also happen with some illegal drugs, particularly MPTP, which probably has a cooler street name, but I don't fucking know what that is. So other things that can give you Parkinsonism are going to be some toxins, some CNS infections like mad cow disease, and atypical Parkinsonism, which is just linked with underlying diseases like things like Huntington's. Okay, cool. So now we kind of have an understanding of some risk factors for Parkinson's disease and other things that might give you Parkinsonism. But how do I know? How do I diagnose a patient with Parkinson's disease? What is the definitive way to do it? The short answer to that is there is no definitive way to do it. So Parkinson's disease is a clinical diagnosis because the definitive diagnosis can only be made post-mortem when you can look into the substantia nigra and find the Lewy bodies. So in real life, what you will do is you will refer to a specialist. But we'll talk a little bit about inclusion-exclusion criteria because, we don't want that specialist to hate you. What are things that will support you suggesting that a patient has Parkinson's disease? First things first is Parkinsonism. If your patient has that classic triad, that's very helpful. The other thing that can be kind of helpful in indicating that it's Parkinson's disease is if your patient has a clear response to dopaminergic therapy, or, if the administration of levodopa helps alleviate symptoms. And then the final thing that can really help you say, I think this is Parkinson's disease and not another cause of Parkinsonism, is either the presence of olfactory loss or if you have cardiac sympathetic denervation. And I don't know why, but both of these features have a greater than 80% specificity for being Parkinson's disease rather than another cause of Parkinsonism. So, okay, and then there are actually a ton of absolute exclusions and other red flags that would lead you away from thinking that something is Parkinson's disease. And I could go through this individually, but I'm actually just going to summarize it because it's extremely long and I'm a tired and lazy person. So Parkinson's disease has a pretty well understood progression and a pretty well understood impact on the brain. Anything not consistent with that is going to diminish the likelihood that what you're looking at is Parkinson's disease and not some other cause of Parkinsonism. So things like rapid progression of gait impairment or observable changes to other parts of the brain that aren't the basal ganglia, or, symptoms failing to progress, or, a lack of response to treatment, or any additional unexpected sign or symptom is going to push you away from this being Parkinson's disease. And I said it before, in order to make a definitive diagnosis of Parkinson's disease, you don't need imaging, right? Because you can't, but it can still be useful because it can rule out other things. Mostly what you'll be looking at are MRIs or DAT scans, and that's because a conventional MRI can be used to rule out strokes or tumors as a cause. DAT scan can be used to visualize striatal dopamine transporters via CT, which can be helpful for determining if something is a Parkinsonian tremor or a different kind of thing like an essential. Boy. The word I wanted there was essential. It helps you determine if it's a Parkinsonian tremor or an essential tremor. And the DAT scan is particularly helpful when the levodopa test is inconclusive or negative. There is also, and bear with me, a thing called iodo-benzamine single photon emission computer tomography, or IBZM SPECT, or IBZM SPECT, which measures D2 receptor density in the striatum. And it usually, that test should be normal in Parkinson's disease, or maybe show increased receptor density, versus in things like atypical Parkinsonism, where it will be decreased. All three of these can be used to kind of say, it's not something else, so it's probably Parkinson's disease. Okay, that was horrible. But okay, now we have determined this patient has Parkinson's disease and not some other cause of Parkinsonism. So now what do we do? Short answer, we refer them to a specialist. Sorry, I'm joking, I promise. Okay, so treatment should be initiated and guided by a specialist, and it's gonna have to end up being tailored to your individual patient and their different responses to medications, but I'm gonna talk through it, I promise. Now, importantly, there is no cure for Parkinson's disease, so treatment is going to be focused on controlling symptoms and minimizing side effects. And there are a bunch of pharmaceutical kind of interventions that we have, and they're all aimed at raising the circulating level of dopamine. Our big drug for this is levodopa, and levodopa is fully just a synthetic dopamine, and it can be taken orally and it'll boost the patient's dopamine levels. Now, it'll usually be combined with another drug because we don't want the dopamine to break down in the body, we want it to go into the brain. And so what we give them are peripheral decarboxylase inhibitors, and our common peripheral decarboxylase inhibitors are carbidopa and benserazine. You guys are not in these videos because I know how to pronounce drug names. Benserazide. That's what it's called. And conveniently, these are often formulated already combined. So we have co-benyldopa, which is levodopa and benserazide, and we have carldopa, which is levodopa and carbidopa combined. Levodopa is by far our most effective treatment for symptoms, but it becomes less effective with time. So it's often reserved for when other treatments are failing to manage or control symptoms. And it also, of course, has side effects. The main side effect of dopamine occurs when the dose is too high, and that's when patients are going to develop dyskinesias. And dyskinesias are just abnormal movements, and they're associated with excessive motor activity. And some examples that you'll see in these patients are dystonia, chorea, and athetosis. Dystonia is there's excessive muscle contraction, and that's going to lead to abnormal postures or exaggerated movements. Chorea, there are these involuntary movements that can be kind of jerking and random, and it's called that because it looks a little bit like dancing if you don't know how to dance. Athetosis are these involuntary twisting or writhing movements, and those are usually going to be in the fingers, hands, or feet. Our next drugs that we care about are COMT or COMT inhibitors, the main example of which is entacapone. And yes, I do always think of Al Capone when I talk about this drug class. So these are inhibitors of catechol-O-methyltransferase, or COMT. And what COMT enzyme does is it metabolizes levodopa in the body and the brain. So, when you give a COMT inhibitor like entacapone with levodopa, it's going to kind of boost its functionality. It slows the breakdown of levodopa in the brain and therefore extends its duration. So the next drug we're going to talk about are dopamine agonists. And so they mimic dopamine in the basal ganglia and they stimulate the dopamine receptors, right? Because that's what agonists do. But they are less effective than levodopa in reducing symptoms. So what they're actually used for more commonly in practice is to delay the use of levodopa in a patient's sort of therapeutic journey. And then they are used in combination with levodopa to reduce the amount, the dose of levodopa that the patient needs to be on. They do have a pretty important side effect associated with their prolonged use, and that's pulmonary fibrosis. Like our COMTs were the Capones, our dopamine agonists tend to be goline, G-O-L-I-N-E. So you have paragoline and carbogoline. And then, of course, for no apparent reason, bromocriptine. I hate drugs. I just hate them. Okay, our last major drug class that we're going to talk about is monoamine oxidase B inhibitors. So a monoamine oxidase enzyme it breaks down neurotransmitters like dopamine, serotonin, and adrenaline. And these monoamine oxidase B enzymes are more specific to dopamine, so they don't act on serotonin or adrenaline. And these medications, therefore, they block the activity of this enzyme and therefore help increase the amount of circulating dopamine by reducing the amount of dopamine that's broken down. Similar to dopamine agonists, they're usually used to delay the use of levodopa and then in combination with levodopa to kind of reduce the required dose. And our examples of that are selegiline and rasagiline. Drugs that end with G-I-L-I-N-E. Great, so now that we've talked about our big classes of drugs, we can be done. Of course not, because Parkinson's disease is not just about treating Parkinsonism, it's also about treating associated symptoms. So, for example, patients with Parkinson's disease often have depressed mood. So you want to treat those things pharmacologically as well. So you might be giving them SSRIs or SNRIs. Now you need to be careful because those cannot be combined with MAOA-B inhibitors. And you have to be extremely mindful of this because patients with Parkinson's are at higher risk of suicide. So it's imperative that you find the right way to support these patients. Sorry, y'all. My phone died. So, yeah. Don't exactly remember what we were talking about, but we're just gonna pick up where we were going. So, other things that are associated with Parkinsonism that you might be treating pharmacologically are going to be things like dementia, where you might be using cholinesterase inhibitors, or psychotic episodes where you'll be using atypical neuroleptics like clozapine, or detrusor activity, like we talked about, kind of urge incontinence and stuff like that. So you might be giving them anticholinergics, for both that and for the tremor. There's also insane shit like deep brain stimulation. That's pretty much for patients who have the severe motor symptoms who are not responding to levodopa treatment, or, they're not sufficiently controlled with levodopa treatment, or, if they need a decrease of that dosage for some, reason. Yeah, and so that basically works by we insert electrodes into your brain and we leave the wires hanging out so we can connect them to a pulse generator. Is nuts, and it is associated with some pretty severe side effects like infections or hemorrhages or, breakdown or displacement of electrodes or leads. But it does work, so, that is a thing to be mindful of. The other thing you need to remember is that drugs and insane surgeries are not the only option for these patients, right? You want to see your Parkinson's disease patients hooked up with a team that can help them manage their symptoms. And that's going to be things like physical therapy and speech and language therapy, occupational therapy, and support groups. And people can help them make their homes safe and comfortable for themselves. And yes, there is no cure for Parkinson's, but a diagnosis of Parkinson's should not be a life sentence, right? Good management of symptoms and a prolongation of independence and management of the activities of daily living are crucial for giving these patients the kind of support that they need. So yeah, before my phone dies again, I think that that's kind of everything you need to know about Parkinson's disease. And, for all that other stuff,